Welcome to my senior lecture. So it's called How Clinically Irrelevant Details Have Shaped My View of Medicine. Yeah. So if you've ever worked with me, you know that I really like taking deep dives into pathophys. But I wasn't really always like that. I think during medical school, I was like most people. I pretty much heavily relied on board questions. And at some point in residency, I switched over from like flashcards and board review questions to doing a lot of like pretty intense reading about like a mechanistic aspect of disease. And I feel like a lot of people look like Micho here with his mustache. You know, and they were pretty skeptical. And a lot of times I feel like people, you know, would think that I probably had something better to do with my time and effort. So I made this lecture to defend myself and hopefully convince you as well that maybe I was right. So this is my philosophy. So I think we get better at what we practice. But the way we practice changes what we get better at. So the thought is, if you practice hitting a ball on a tee, you will eventually get very good at hitting balls off of tees. Unfortunately, that's not really how you're expected to hit the ball, right? This is. So this is my analogy for board questions, and the curveball is your next patient. So when we train ourselves to access medical knowledge based only on board questions, we restrict ourselves in our access to this information. So patients never really present with a hook that is deliberately given to you in a question stem. There's no current jelly stool, and there's no one to tell you that there's pain out of proportion. So in other words, it's a lot harder to remember what you need to know when someone doesn't actually remind you. And on reviewing literature, I found that there's a lot of data about how test scores are kind of good at predicting other test scores. But it seems like clinical decision making is a little bit harder to measure. So I'm not saying board, you know, like doing board questions aren't important, because they make you better at tests and you very much need to take a test to be able to practice medicine. But like once you get the general mechanics of how to hit a ball, I'm not really sure that they help you make better decisions. So obviously the real answer to this is experience, right? That's what residency is for. But that still kind of begs the question is how are you supposed to study, right? Other than coming to work. So this is my concept of learning. So I think most of us at the very beginning, we think of individual facts as information that exists in isolation. So, you know, I think this is how we're trained early in our didactic years when we're in anatomy lab or histopathology. You know, you learn a fact, you commit to studying it, you're asked to reproduce it at a later time on a test, right? And it doesn't really demonstrate understanding. It kind of relies on just basically rote memory. And right, I wrote some of the facts that we all had to know. Klebsiella causes current jelly sputum. There's a lot of references to current jelly. I'm still not really sure what it is. And so, you know, as we study more, I think we begin to conceptualize things a little bit differently. So rather than pieces of information that stand alone, we start to organize them into silos. Pieces of like information pertaining to the same topic get put into the same category. This model of memory works, but it leaves us with a certain perspective of what to do with knowledge that doesn't really fit into one of these molds. You know, we see it as extraneous and ultimately not needed for our clinical development. And so, you know, as I've thought more about it, I think I realized that knowledge doesn't exist in silos either, right? It's a web. And if you categorize it into silos, you miss how disease processes share common mechanisms. And so when we start learning, we start by memorizing and regurgitating facts, but eventually these facts become interconnected and form connections with one another that basically mutually agree with one another. So the whole thought is that pattern recognition in a test question is very easy because the hook is always the same. So practicing the same hook doesn't help you get better at making decisions. So you need a diverse way of approaching the same piece of information, because pattern recognition in real life is complex and variable, and it's usually incomplete in its presentation. So you want to have a lot of hooks. So let's practice making some connections. Part of this was a setup to let me ramble about pathophys. All right, so this is how all of you look right now. All right, so first question. Why can I use magnesium for everything? So have any of you ever wondered like what the connection is between like asthma and eclampsia and torsades. Like why can we use magnesium for all of these different things, right? So it turns out magnesium cations and calcium cations actually look kind of structurally similar. So much so that magnesium blocks extracellular calcium for things that have calcium channels. So as it turns out, this mechanism presents itself in a lot of different ways. So calcium channels are needed for the smooth muscle contraction in the bronchi, leading them to have bronchial relaxation when administered in asthma. It blocks an NMDA channel, which are excitatory calcium channels acted on by glutamate in the brain to prevent seizures, which is used in eclampsia. And finally, it blocks the calcium channels in phase 2 entry of the action potential cycle, and it shortens the duration. So it effectively stops triggered ventricular tachycardia in torsade point. So let's talk about the concept of motifs, right? I kind of first learned about motifs when I was an undergraduate in music. And I had a lot of classes that were pretty fun. I got to wake up at like 10 a.m. and I had a class where we just got to sing and clap all day. But I also spent a lot of time sitting down and staring at sheet music. So this is a picture of a famous musical motif that I think all of you know. It's Beethoven's Fifth, which is the da 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 dum, right? It's a symphony made entirely from those 4 notes, right? It's a very complex structure. But the pieces that make it up are actually quite simple, right? So almost all mediums of art have this concept of motif. So literature has it, it's in visual arts, it's in music, and it's also in nature. So our DNA is filled with repeated sequences, and these repeated sequences make different proteins with repeated structural conformations, and these repeated conformations make up the calcium channels in your brain and in your lungs and in your heart, and they're motifs. So we can use these motifs to reorganize our information. So organization by mechanism as well. And so based on this new information, we relate it to things that were otherwise difficult to compare. So even though we may never be asked to demonstrate the mechanism of magnesium, understanding it helps us relate different disease processes that we wouldn't have been able to relate otherwise, right? Reactive airway, eclampsia, and torsades. So don't be afraid, right? I also just wanted to include these pictures. There's an incredible amount of pictures of Trevor with all different kinds of expressions, and it's like no one else. So while we think that learning something superfluous is somehow going to take up space in our brain that we, from something that we actually do need to know, the opposite's true, right? The more we understand, the more we retain, because we have more information to contextually relate it to. All right, so I feel like I'm now obligated to teach you something clinically irrelevant. All right, so why do paresthesias occur during panic attacks? So I'm going to give you some information and then we'll explain it. And so the whole point of this vignette is to find the motif, right? So the first step in understanding, right? So we have to understand that calcium exists as complex proteins and then ionized. So about 50% of it's ionized. But the thing is, this ratio changes when we change the pH in our body. All right, so calcium's positively charged and it binds to our negatively charged proteins. The most important being albumin. So this is why, if you've ever thought about it, this is why we take albumin into account when we look at calcium in the blood, because the portion we really care about is the ionized fraction. So pH changes the ratio of calcium that is bound to albumin. So an acute change in pH changes the ratio. When we become alkalotic, there's less hydrogen to bind albumin and calcium takes its place. So as we become alkalotic, we actually decrease the amount of ionized calcium in our serum. So this occurs during a panic attack. So if you imagine you start hyperventilating very fast, right? The hyperventilation causes an acute alkalosis, which leads to a decrease in ionized calcium. So why do we care about that? Well, it turns out ionized calcium is very important in regulating voltage-gated sodium channels. So ionized calcium allosterically modifies sodium channels to be more or less excitable. So a change in ionized calcium changes the threshold at which they activate. So a decrease in ionized calcium lowers the threshold needed to depolarize. So they become more irritable, right? So a sodium channel needs less stimulus than before to create an action potential. So when you hyperventilate, you lower the serum ionized calcium, and this causes ectopic discharges, right? And that's felt in the somatic neurons, and that's perceived by paresthesia in the brain, right? It's also the same reason why if you put a tourniquet on, you get paresthesia. Only it's a different reason that causes the ectopic discharges. All right, so now that I have all of your attention, let's try another vignette, something that seems unrelated, but let's try to find the commonality. Right, so why do we use calcium for hyperkalemia? So let's just talk for a second about hyperkalemia, right? So if any of you wanted to forget this, I won't let you. Cardiac myocytes depolarize with an inward sodium channel and repolarize with an outward potassium gradient, right? Hyperkalemia makes it harder for cells to repolarize by changing that gradient. So the more K that's on the outside, the harder it is for it to leave the cell. And so it's unable to get back to its truly negative state. So instead of going down to like -90, it goes down to like -80 millivolts. So this is a nice little graph that shows this. So notice the difference between the resting potential and the threshold potential in hyperkalemia. So normally we have a difference of about -20 millivolts, or we have a difference of about 20 millivolts between our resting potential and our threshold potential. When we have hyperkalemia, that resting potential gets moved up. And so now we have a much smaller difference between our resting and our threshold potential. This increases the chance of ectopic discharges. And this is what it means when we say that there's cardiac irritability, right? So does this already start to sound familiar from what I was talking about before? Hopefully. All right, so think back to the last topic, right? So if low ionized calcium decreases the threshold at which sodium channels fire, what do you think high ionized calcium does to it? Right, it raises it. So if you decrease the ionized calcium, right, it makes them more likely to fire. And if you increase the ionized calcium, it makes them less likely to fire. So it restores that difference in threshold potential, and it decreases the likelihood of ectopic firing. So this is what we mean when we say that the calcium stabilizes the membrane, right? It does it by the same mechanism of ionized calcium modulating voltage gated sodium channels that we discussed earlier. Neat. Right? So what was that stupid mnemonic again that we had? It was like bones, psychiatric moans, with scones, some student loans, erotic undertones. So, you know, now the thought is that we don't need this mnemonic as an anchor to remember this information. You know, we can think, why does hypercalcemia cause, you know, so does hypercalcemia cause seizure or coma? I could never remember this until I learned this mechanism, right? Hypercalcemia causes coma. Why? Because it does it by the same mechanism, right? It makes your neurons less likely to fire. So do you see? So the things that seem unrelated have a shared mechanism, and we use these connections when analyzing clinical data. A well-rounded understanding of a subject gives us many hooks by which to remember a piece of information when it's relevant. So I just wanted to say, I owe a lot to all of you, right? Certainly the people in this program are the best part. To my co-residents during the last 4 years, I have envied you. I have tried to emulate you, and I've certainly done more for for my patients, because the person next to me was pushing themselves even harder. We've been through a lot together, right? And I'll certainly always remember you. So what's the take home of this lecture? Everything in medicine is interrelated. Connections exist between all different symptoms, pathologies, and diseases. There are motifs everywhere, and finding them can reduce the complexity of understanding the world around you. And we exist in a privileged place where we get to see all types of presentations in human pathology. So don't be afraid to indulge your intellectual curiosity. Try to explain the world around you, make connections, and I think you'll be a better doctor for it. I can't wait to see all of you in the next chapter. And this is me after residency.